Will come to order. As this hearing is fully virtual, we must address a few of the housekeeping matters. For today's meeting, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating inadvertent background noise. Members are responsible for muting and unmuting themselves. If I notice that you have not unmuted yourself, I will ask you if you would like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. I remind all members and witnesses that the 5-minute clock still applies. If there is a technology issue, we will move to the next member until the issue is resolved, and you will retain the balance of your time. You will notice a clock on your screen that will show you how much time is remaining. At 1 minute remaining, the clock will turn to yellow. At 30 seconds remaining, I will gently tap the gavel to remind members that their time is almost expired. When your time has expired, the clock will turn red, and I will begin to recognize the next member. In terms of the speaking order, we will begin with the chair and ranking member, then members present at the time the hearing is called to order, will be recognized in order of seniority, and finally, members not present at the time the hearing is called to order. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing at any of our hearings or markups. That email address has been provided in advance to your staff. With that, let me begin. I want to acknowledge Ranking Member Congressman Cole and all of our colleagues for joining us today. If there is one thing we have learned from the COVID-19 pandemic that has raged across our nation over the past year, it is that our nation's public health infrastructure is extremely fragile. Simply put, we are not adequately prepared to respond to public health emergencies of this scale. Dr. Schuchat from the CDC observed in our COVID-19 member roundtable yesterday, and I quote, "Emergency resources are very different than sustainable longitudinal capacity. And what health departments really need is help," and quote, "improving the data, improving the workforce, skill sets, and improving the lab capacity." Even now, a full year into this pandemic, the virus continues to move faster than our ability to collect, share, and analyze the data. Decisions are being made based on stale information. During our public witness day in 2019, this subcommittee heard about health departments and labs that still use fax machines to communicate. In many cases, data has to be re-entered by hand. Health agencies analyze data retrospectively rather than with an eye to the future. Effectively, that means even data as basic as a patient's demographic information, race, ethnicity, or pregnancy status is not being electronically transmitted across health providers and agencies. And that lack of communication can have serious consequences. For example, to answer the question of how COVID-19 affects pregnant women, researchers must first figure out who is pregnant, as there is not sufficient data on who is pregnant. In response to this health data transmission problem, we championed the Public Health Data Modernization Initiative at the Center for Disease Control and Prevention. This subcommittee has provided a total of $100 million for the CDC to start the Data Modernization Initiative in fiscal year 2020 and 2021. The labor appropriations bills on a bipartisan basis as well in 2020 included an additional $500 million to be directed to data modernization in the CARES Act. Unfortunately, when the coronavirus hit, this multi-year data modernization initiative was barely getting off the ground. Turning more broadly to health departments across America. And let me just make this point, which is made by one of our witnesses this morning. State and local public health officials are the foundation of every public health response. A year into the pandemic, they are still understaffed. Our health departments are still understaffed. Following the Great Recession, local and state health departments have lost more than 20% of their workforce since 2008, shedding over 50,000 jobs across the country. This staff shortage has worsened because as much as 1/4 of our health workforce is eligible to retire. In fact, 22% of the workforce plans to retire in the next 5 years, many more moving to the private sector. 25% plan to leave public health for reasons other than retirement. And overall, this means nearly half of the health department workforce is leaving their organization in the next 5 years. And the COVID-19 pandemic certainly hasn't improved matters. We need to look at our workforce. We need to make sure that there is diversity and equity. We need to incentivize and hire a whole new generation of public health staff, and we need to do it now. Our public health departments and laboratories must be equipped with the capacity, the equipment, and again, a diverse and trained workforce that they so desperately need. I think this is a very, very interesting statistic which was brought out in Dr. Bibbs Freeman's testimony. Public health laboratories are essential for the public health practice. COVID-19 has shined a light on the capability, the workforce, and data modernization needs in our nation's 110 public health laboratories. Dr. Freeman's testimony states, and I quote, in March of 2020, 3% of all public health laboratories and only 3% in the country were capable of performing the advanced molecular detection tests needed to combat COVID-19. Just 3%. This is an example of the virus being able to move faster than our public health capabilities. Dr. Freeman's testimony highlights the challenges of recruitment and retaining a diverse, qualified laboratory workforce. We need to invest in not only the equipment that public health laboratories need, but the people. These are not one-time budget requests. Though Congress has provided more funding to local, tribal, and territorial public health organizations to respond to the pandemic over the past year, we have much to do in order to make this a lasting difference. We are here today to learn more about how these supplemental funds have been used, how much more we must provide to adequately meet the challenges of the ongoing COVID-19 response, which is why we will need our witnesses and others in the public health arena to tell us what you need, especially in terms of the long-term challenges of the public health workforce and what we need to do to build that architecture for the future. But while the national attention has been laser focused on the impacts and challenges of the COVID-19 pandemic, it's important for us to keep in mind that this is just one of the many battles our health system is facing. I want to mention one or two other pieces here, if I can. This pandemic is only compounded by the already existing public health crisis of youth vaping, the anti-vaxxer movement, the rise in food safety challenges following the past administration's deregulation of the food industry. These are challenges, and they're reasons for us to invest in our public health agencies, which in turn keep our communities healthy and functioning. Historically, as a nation, we appreciate the need for a strong public health system when we are in the middle of a public health crisis, but never before. We think about it in the midst of, but never before. If we want to have a public health system that is prepared, we need to invest now in personnel and labs, equipment, and data systems, not just this year, but every year, and not forget about this when the pandemic subsides. I will reintroduce the Public Health Emergency Fund, which would provide $5 billion to the existing Public Health Emergency Fund, which was created in 1983, but is currently empty. By dedicating funding ahead of time, this bill would enable our public health agencies to respond quickly to these emergencies. We have provided billions for an airline industry, billions more for small business through the Paycheck Protection Program. We needed to do that. It is only logical that we would need to invest as much, if not more, in the very systems designed to keep us healthy and safe from this disease. We saved the airlines. We have saved small businesses. We now need to be in the business of saving lives. This is not about throwing money at a problem. This is about creating a stable, solid, sustainable public health infrastructure system for the future. The witnesses we have joining us today represent key partners in public health. We will gain perspectives from the state health department, a local health department, and a public health laboratory system. We will learn about these institutions and their roles in COVID-19 pandemic response, what the needs are in the field, and the recommendations for strengthening our public health infrastructure. To meet the moment, we need to transform our public health infrastructure. The health of our families and our communities depend on it. And with that, I would like to yield to the ranking member of the subcommittee, Congressman Cole, for opening remarks.
Thank you very much, Madam Chair. Before I begin my formal remarks, I want to tell you how impressed I am with your background. I have an old saying that if I know what you read, I know who you are. So I've been straining looking at the titles, and I'm pretty impressed with our chairman. And I'm also dazzled by this collection of athletic memorabilia, baseball and football that you have behind you. It's pretty impressive. It speaks of a very well-rounded person.
Oh, Yankees.
And I very much want to associate myself with some of the points you made about the importance of the topic we're talking about. I want to thank you for this hearing. I think it's a really important hearing, and I think these investments are important. As I've told our own side, and I think the last year has illustrated to all of us, sometimes you need to spend billions to save trillions. And just look at the cost of what this pandemic has been and think of the difference some of the very investments you talked about and laid out in your opening remarks might have made had they been available earlier. And I know you've been a constant champion of this throughout your career. So I again, very pleased to have your leadership at this critical point for our subcommittee. I know that the COVID response continues to be at the forefront of everyone's mind. And the public health experts are front and center in defending our people. In addition to hearing about COVID this morning, I'm hoping that we can also discuss other priorities I know we all share, such as reducing opioid abuse, overdose deaths, addressing the threat of antibiotic resistance, and preventing the growing problems associated with chronic diseases. All critical public health issues for our country, but all issues that require a robust public health infrastructure to deal with over time. 6 years ago, Congress began shaping policies and prioritizing investments in our readiness, including boosting funding year after year for the National Institute of Health, the Center for Disease Control and Prevention, and the Strategic National Stockpile, all in an effort to prepare our country to be able to quickly respond to a pandemic such as COVID-19. And we created new tools like the Infectious Disease Rapid Response Fund. These accomplishments were done on a bipartisan basis and driven not by any administration, but by Congress itself. It's my hope that this year Congress will once again assume a leadership role in the areas of biomedical research and public health preparedness. Unfortunately, our experience over the past year has shown while we have done much, we still have much to do in the area of preparedness and modernizing the public health infrastructure. Despite many heroes working tirelessly on the front lines, we encountered many challenges with technology, infrastructure, and basic access to supplies and other resources that added frustration to an already difficult situation. I'm grateful to our healthcare workers and public health professionals for continuing to press ahead and save lives over the past years in the face of enormous difficulties. One of the programs I am most proud of during my tenure as chairman of the subcommittee was the establishment and investment in the Infectious Disease Rapid Reserve Fund, which was immediately available to the public healthcare system to respond to COVID. And I want to thank our chairman for not only continuing that program, but frankly, investing even more robustly in that program. Again, this was a bipartisan accomplishment. Indeed, because Congress had the tools in place ready to deploy at a moment's notice, we were able to respond quickly before an initial funding supplemental was passed. This outcome was the aim in our creation of the reserve fund. And while it was unfortunate we had to use the fund, I'm glad those resources were available. And again, I associate myself with my friend, the chairman's remarks about the need to continue to do that and build upon that going forward. While there's a long road ahead with many unknowns, I'm encouraged that one of those unknowns is not whether the funding will be there for public health defenders to continue in their response. Congress has provided unprecedented funding for these unprecedented times. I'm hoping that at this hearing today, we can talk about what has worked, what went right, what these resources are doing to build up our infrastructure, and where gaps remain, and what we should be doing going forward to fulfill those gaps, and again, make sure that we have a system that is robust enough to defend us from the challenges that the biosphere will surely present us with again in the future. As we discuss this today, I'm hoping we can also move beyond the specifics of COVID and have a broader conversation about the areas of public health that need to be further modernized to respond to other threats as well. As we've unfortunately seen and are continuing to witness, a deadly new disease is literally just a plane ride away. We need to be ready for the next threat and not just prepare to fight the last war. Moving rapidly to contain other communicable diseases such as influenza, combating the opioid epidemic, making progress toward treating chronic diseases that threaten our most vulnerable populations, and reducing antibiotic resistance are all key challenges in our public health mission. We need to be sure we're ready to tackle them. Each may require a different approach, and all will almost certainly require additional investments and resources. Thank you for your work to our witnesses on the front line to protect all our people from this pandemic and from other threats in the public health. We're grateful for your service. We look forward to your insights. And again, Madam Chair, I want to really thank you for holding this hearing. I think it's an extraordinarily important hearing because I don't think there's anything more important than we do than the work in these particular areas for all the American people. So thank you for your many years of leadership, and I look forward to working with you on this as we go forward together. Yield back.
Very, very much. And I think it's so clear that we are really joined in this effort. We understand what has happened, what hasn't happened, and what we need to do. And it's now time, while we've shown a light on some of these other areas of our economy that have cratered, that is now time to talk about what's happened to our public health infrastructure and shine that light here. Because as you pointed out, this is about saving people's lives, and there isn't anything more important than that. So I want to thank you, Congressman Cole. With that, let me I'm going to introduce our witnesses. I am delighted to welcome Dr. Catherine Turner, who is Deputy State Epidemiologist and Chief Bureau of Chief Bureau of Communicable Disease Prevention in the Idaho Division of Public Health. Dr. Marilyn Bibbs Freeman, Deputy Director, Division of Consolidated Laboratory Services in the Commonwealth of Virginia. Ms. Jennifer Cardenas, the Director of Health for the Farmington Valley Health District in Connecticut. Farmington Valley neighbors my district, and we know well now that the viruses do not stop at any borders. So I want to just say that thank you, Ms. Cardenas, for your work, and it impacts my constituents, and for that we are grateful. A graduate of Southern Connecticut State University, is currently an adjunct professor there as well, which is located in my district. And I would just say, go Owls. And Dr. Umair Shah, who is Secretary of Health for the state of Washington. With that, Dr. Turner, you are now recognized for 5 minutes, and your full testimony will be entered into the record.
Thank you. Chair DeLauro, Ranking Member Cole, and members of the subcommittee, thank you for the opportunity to appear before you today. I'm Kathy Turner, a public health epidemiologist or disease detective, and I currently serve as Idaho's Deputy State Epidemiologist. I'm also a board member of the Council of State and Territorial Epidemiologists, and I'm here today representing CSTE. Our job is to investigate outbreaks, no matter how large or small, and identify the cause of the disease, the people at risk, and how to control the spread. We are now in the second year of a grave public health crisis that has exposed deadly gaps in our public health data infrastructure. And while COVID-19 is just the latest threat demonstrating that our public health data systems are outdated, it's not the last public health threat that we'll face. Led by CDC, state and local health departments across the country need a nationwide public health surveillance system to detect emerging health threats and facilitate immediate response for their individual populations. What does a strong nationwide public health surveillance system really look like? Well, the reality is we have many of the pieces in place, but we need to make larger, regular investments to modernize our systems, connect them using current technology, and ensure they have the resources they need to stay up to date when technology advances. Using COVID-19 as an example, let's examine a small piece of the data pipeline to better understand how data flows from providers to state and local public health. When you visit your doctor with a suspected COVID-19 infection, the doctor will order a laboratory test. Remember, your doctor has a lot of important information about you: your race, ethnicity, sex, pregnancy status, and vaccination status, and demographic data, including your address and phone number. When the test is complete, your results are sent to your doctor. And because COVID-19 is a reportable condition, the lab must also report the results to the health department. And while lab results are typically returned to the provider electronically, they are often reported to the health department by fax or by phone, and the results are almost never accompanied by the critical demographic, racial, and ethnicity data. A full case report that would include more robust information is often never received by public health, despite the data collected in the patient's electronic health record. Every day, my team spends valuable resources tracking down addresses and phone numbers for positive cases, and without data on race, ethnicity, and pregnancy status, public health cannot use the data to protect those communities most at risk. In today's digital world, we have to make our provider systems interoperable. In other words, let them talk to our public health systems and pass on the required data. State and local health departments must also share essential de-identified data with the federal government, where it's used to develop national policies to reduce morbidity and mortality and protect those most vulnerable. Data help to identify hotspots, new strains, and emerging threats. We cannot and should not make essential policy decisions without timely and accurate data. But if we don't have those data, we cannot share them. It's that simple. CSTE initiated the call for improved public health data systems before COVID-19, and it's now critical that we transform our existing public health data system to live beyond this pandemic. There are 5 pillars that must be included in public health data modernization that I outline in detail in my written testimony. Those 5 pillars are electronic case reporting, also called ECR, syndromic surveillance, the electronic vital record system, laboratory information systems, including electronic laboratory reporting, and the National Notifiable Diseases Surveillance System. Without a modern public health data infrastructure in place, we will continue to face obstacles in responding to public health threats. For instance, multi-system inflammatory syndrome in children is a complication of COVID-19 and not identified in a laboratory. It is reported by providers who diagnose the symptoms. Without electronic case reporting and syndromic surveillance, discovery of this dangerous complication is delayed while public health fields phone calls and reviews faxed medical records. Another essential component of public health data modernization is a skilled workforce that includes epidemiologists, public health informaticians, data scientists, and other experts, all of whom work together so that the public health surveillance system is ready for the next pandemic. We do not have a science problem. We have a resource problem. The core data systems for national infrastructure already exist. To make it work now and in the future, we need regular, sustained annual funding, and we have to start somewhere. We respectfully request the subcommittee provide annual funding of at least $100 million for the Public Health Data Modernization Initiative at CDC. Thank you. I look forward to your questions.
Thank you very much. Dr. Bibbs Freeman?
Good morning, Chairwoman DeLauro, Ranking Member Cole, and all assembled representatives. My name is Dr. Marilyn Bibbs Freeman, and I work for the Department of General Services, Division of Consolidated Laboratory Services in Virginia. I'm also a member of the Association of Public Health Laboratories, where I also serve as the chair of the Diversity, Equity, and Inclusion Task Force. I'd like to thank you initially for the funding that is already available through a variety of packages dedicated to COVID-19 relief, as well as data modernization. Today, I hope to list some challenges as I see them, describe their impact, and propose solutions where applicable to address the challenges. I'd like to just start by saying that while the COVID-19 pandemic did not elucidate any unknown weaknesses in our current system, it did exacerbate those that we already knew. Personnel are our most valuable as well as our most costly asset in the public health industry. For reasons related to salary compression and otherwise non-competitive compensation, these items have resulted in minimal or no salary increases over time. The impact is significant impacts to morale. Employees who have vastly different skills and knowledge sets are paid the same amount of money for extended periods of time. Additionally, it becomes very easy to find employment in private industry where compensation is higher, oftentimes for the exact same job or similar job. We're unable in public health to compete with that. Ongoing and dedicated financial support to ensure that employees are paid commensurately with their skill set, but also competitively with the current job market is essential to meeting the needs of the current workforce. In coming years, as Chairwoman DeLauro indicated, we are facing crippling attrition, and up to 41% of our workforce in some public health laboratories are within retirement age, and then we have another 31% that are considered millennials and planning to leave within the next 5 years. Not only does significant attrition affect our ability to deal with basic public health laboratory testing needs, it also threatens to make impossible our ability to respond to urgent public health threats such as COVID-19. Feedback from our employees indicate that salary and job satisfaction in the form of skill development as well as knowledge investment will assist with retaining them here in the industry. But I think we also need to take the time to look at creating a pipeline for public health laboratory science. There are actually no public health laboratory science undergraduate programs currently in the country, and of the 3 graduate programs specifically designed for public health laboratory, one of them is currently not accepting applications. Funding educational facilities to create and expand programming for public health laboratory science is an innovative approach to ensuring personnel are available to address future public health vacancies. The majority of public health employees are Caucasian women who are paid disproportionately less than men in our setting. A lack of diversity within our current workplace threatens to increase turnover due to feelings of not being included. Additionally, research demonstrates that we are able to maximize our talent by simply improving the diversity of the business. One solution can be found in grant application requirements. Having laboratories define their diverse recruitment strategies or other DEI activities within a grant submission is an active and intentional approach to fostering a diverse work culture from the top down. A second option is to require each governmental public health entity to have an assigned diversity, equity, and inclusion professional on site or otherwise easily accessible. I'd like to kind of move on to our data management, which has been discussed at depth by Dr. Turner. It's a fact that our current data management strategies no longer address the expanding needs of public health. The issues are varied and expansive, but include outdated software and legacy hardware, where upgrades are difficult because versions are no longer compatible or supported by the vendors where we have purchased them. This makes it difficult to utilize applications such as cloud-based computing, mobile computing options, and storage for the management and analysis of large data sets. It further limits the laboratory testing equipment that can be purchased for the use of public health advancement. Data modernization is truly a situation where we have placed a bandage over the problem, but COVID-19 has pulled it off. We have been unable to quickly or easily implement system modifications that will support things like patient registration portals, COVID-19 variant analysis, or information management system upgrades. Dr. Turner also alluded to health information exchange between one agency to another. We need to be able to seamlessly transfer information between agencies in a secure manner to mutually benefit both parties. Our inability to efficiently exchange health information impedes the prompt allocation of services to the communities that we have been dedicated to serve and support. A continued, ongoing funding strategy that takes into account yearly inflation for supplies, market comparisons, and other direct and indirect cost increases of doing business is needed to maintain all elements of data modernization incrementally over time instead of more costly, less efficient, instantaneous overhauls as we are doing now. Thank you for your time.
Thank you very, very much, Dr. Freeman. Ms. Cardenas?
Hello, everyone. Good morning, Chair DeLauro. It's great to see you. I wish we were in person. Congressman Cole and members of the subcommittee. My name is Jennifer Cardenas. I am the Director of Health for the Farmington Valley Health District. We serve a population of 110,000 and 10 towns just north and west of the Hartford, Connecticut area. I also serve as the current president of the National Association of County and City Health Officials, the association that represents our nation's nearly 3,000 local health departments. I want to thank you for the opportunity to speak to you today about the critical importance of our nation's local public health system, the vital work that we do, and the importance of investing in a robust and well-funded public health system. While many of my public health colleagues at the federal, state, and local level have long advocated for a robust and well-funded and well-supported public health system, there is nothing like a pandemic to illuminate the real impacts of years of disinvestment on our response efforts and the health of our communities in general. I'd like to speak to the following. First, while it is easy to make the case for investment in public health during a crisis, it is the well-funded and supported capacities and functions of a local health department and state and federal health departments before an emergency that best position us to respond to emergencies, be that a pandemic, other disease outbreaks, or natural disasters. Second, the investment in a public health system must be a national priority. For the past year, I have witnessed the incredible efforts of my department and local health departments across the country in responding to this pandemic and supporting the communities we serve. We are the boots on the ground, but the response we have had to mount has been limited by lack of resources and years of disinvestment, including outdated data systems and technology and lack of human resources. The Great Recession of 2008 hit all sectors of local government. However, whereas many of these sectors were able to bounce back, funding for local public health did not recover. Between 2008 and 2019, the average local health department expenditure per capita decreased by 30%. This led to severe workforce reductions, and local health began this response with a 20% reduction in workforce capacity. And one can argue that even at our 2008 capacity, we were still not investing in a robust, well-funded public health infrastructure. The work of local public health, as you have heard, requires the investment of a diverse workforce and skill set, including epidemiology, health educators, environmental health professionals, public health nursing, community health workers, public health information officers, and administrators, to name a few. Since 2008, local health departments report a 1/3 reduction in public health nursing. Pretty staggering considering the work we are currently engaged in to vaccinate our population, not once, but twice. This is but one example. Many local health departments, mine included, did not have an epidemiologist, a public health information specialist, a community outreach worker, or other key public health professionals critical to this pandemic response. Our current workforce is overworked and stressed as they are working tirelessly in an attempt to fill gaps and best serve our communities. With limited staff and a need to focus on our pandemic response, at the local level, we have had to reassign staff. Other public health work has diminished considerably or stopped altogether. Even before the pandemic, the United States did not enjoy the highest life expectancy of developed nations. And in fact, we are seeing reductions in life expectancy prior to the pandemic due to diseases associated with overweight and obesity, particularly among our youth. One illustration of this is CDC's study, which revealed that nearly three quarters of young people were not eligible to join the military if they so chose because of overweight or obesity. Preventable or delayable chronic diseases are taxing our health care system. Our medical expenses in this country are astronomical. And unfortunately, we are seeing how health inequities among certain populations are resulting in higher rates of illness and death among certain segments of our population due to the pandemic. Public health is about prevention, Some of the greatest gains in life expectancy and quality of life are associated with historic public health initiatives. Moving forward, strong federal appropriations that fully fund the needs at all levels of our governmental public health and equitably reaching the local level are key to building back our public health workforce, our most critical public health asset. There are workforce initiatives and bills. We urge support for data modernization that includes local public health. We need data at the local level to ensure that investments are placed on initiatives that address health conditions and risk factors resulting in the greatest risk of premature disease and illness. I'll just finish by saying that the benefits of a strong local, state, federal government public health system has wide-ranging impacts for our nation, including national security, a healthier workforce, better educational achievement, improved quality of life, and more resilient communities during emergencies such as the one we are currently living. Let's learn from this pandemic and make the necessary investments to ensure that all Americans can be confident in the public health system no matter where they live. Thank you again for this opportunity.
Thank you very, very much. And now, Dr. Shah, I think you're back on with us in the video. Is that right?
I am. I apologize. I've been on 3 different technologies. Speaking of.
Well, we're glad to see you. We are glad to see you.
Thank you. Good morning, Chairwoman DeLauro and Ranking Member Cole, members of the subcommittee. Thank you for your leadership and for inviting me to testify today. Let me start by saying I can tell you firsthand exactly why investment in public health infrastructure is necessary. I'm not only a responder, but a survivor of numerous emergencies, natural disasters, hurricanes, chemical incidents, infectious disease outbreaks, and now COVID-19. Each time my own community was impacted. This past week, my family and I survived yet another emergency with a massive winter storm in Texas. While the focus rightfully has been on the immediate aftermath of loss of power as people have struggled to stay warm, we cannot forget the big picture of climate change in leading to extreme weather events. This is a conversation I would love to have, Madam Chair, at a later date. My name is Dr. Umair Shah. In late December, I was honored to be appointed by Governor Jay Inslee as the Secretary of Health for the great state of Washington. Honored because Washington has been a leader in responding to this horrific pandemic. This is a testament to Governor Inslee's leadership as well as the work of our state health agency, our teams, and countless partners on the ground. Previously, I was the Executive Director and Local Health Authority for Harris County Public Health and a past president of NACCHO, and so I'm glad to join with Jennifer here. She is fantastic, and I really appreciate the work that NACCHO has been doing. I am now a proud member of the Association of State and Territorial Health Officials, ASTA, representing state and territorial public health agencies and the District of Columbia. And as an emergency department physician for over 20 years, I've had the distinct honor of taking care of our nation's veterans through the Houston VA Medical Center. Over this past year, we have all witnessed the loss of life, impact on countless patients and families, and communities devastated by COVID-19. It is shocking that we passed another grim milestone this week with 500,000 American lives lost. As a leader in health, I have been frustrated by seeing the strain on our public health system to ramp up epidemiology, laboratory testing, communications, contact tracing, and now getting vaccines into arms. I'm here today, though, not to just express frustration, but to work towards solutions. You have my full testimony today. I will touch on 3 main points. 1, public health truly matters, and there is a cost to chronic underfunding. Number 2, we must commit to investing in a strong and capable public health workforce. And number 3, public health data systems must be modernized so data move faster than disease. So first, public health is vital to all of us. This is truly boots on the ground, performing all sorts of key activities behind the scenes in assuring our communities are healthy, protected, and safe. Yet over the last 40 years, we've spent ever increasing amounts on personal health care and largely neglected public health. During this time, life expectancy, relatively speaking, compared to similar countries, has decreased, and this has only gotten worse during COVID-19. The public's health is headed in the wrong direction. Decreased investment in public health doesn't make us stronger, it leaves us more vulnerable, constantly scrambling to address the next crisis upon us and forces us to rob Peter to pay Paul by taking from elsewhere. The pandemic has been horrific in so many ways, yet it is a transformational moment to build back better. Now is the time to make smart, strategic, and sustained funding in public health infrastructure. In making these investments, we must also address long-standing health inequities. COVID-19 did not start these inequities, but it has made them markedly worse. The inequitable distribution of death and disease means we have seen communities with disproportionate impacts from this pandemic. This is simply unacceptable. To reset, reform, and rebuild, federal investments must prioritize and resource equity. Thank you to this subcommittee for your approval of multiple emergency supplemental bills, which provided funding necessary for the ongoing COVID-19 response. And now it's time for Congress to provide an additional annual appropriation of at least $4.5 billion for public health infrastructure. We must commit to investing in our workforce as well. The Washington Department of Health had to bring on nearly 1,000 more people, and more than 1,000 staff were redeployed to respond to the pandemic. Many other essential public health programs had to put their work on hold as staff were shifted to the pandemic response. Similar actions occurred in Harris County, across the country as well. This is not sustainable. Public health staff have been working around the clock for more than a year in COVID-19 response, are genuinely mentally and physically exhausted, and are leaving the field. We must support these public health heroes, and we need more of them. This is why we need a national effort to hire 100,000 new public health personnel to ensure we can build back a better public health system. Data systems, the lack of investment in at all levels of government has strained our ability to respond to the everyday and to emergencies. Given advances in technology, there is no excuse not to invest in the tools necessary to help our teams do their jobs efficiently, effectively, and equitably. Annual funding of at least $1 billion for CDC's data modernization initiative and across all levels of public health is a necessary step to modernize data systems. Let me close by saying public health infrastructure funding should be seen as an investment and not a line item in a budget. Public health is the invisible offensive line of a football team, and we are not doing enough to support and invest in that offensive line. We keep focusing on the quarterback. We have had an invisibility crisis in public health for far too long. If nothing changes, we will get more of the same. Systems without the robust capacity and capabilities to respond to the next emergency. We are at a crossroads. Either we can act now and invest in public health, or react later and overspend dearly to undo that which should and could have been prevented. On behalf of the state of Washington, ASTO, and my colleagues across the nation at all levels of government, I appreciate the opportunity to testify today. We look forward to working with you in building safe, healthy, and protected communities across this great nation of ours. Thank you.
Thank you. I would make a comment, and I'm going to now move to my question, and I've two questions, so I want to do that quickly. And but we've listened to a lot of testimony in this subcommittee over the years, and a lot of powerful testimony. There has been such a sense, and I think the ranking member would agree, such a sense of consistency. It was almost, you are all talking about the same thing. There's no different approaches. It is this singular effort that if we don't make it, we rue the day. So I'm just very, very powerful testimony. And with that, let me just I'll try to get my two questions in. Dr. Turner, the CDC's data modernization initiative that we have begun to reduce the amount of effort that is spent chasing the data, whether it's address, gender, etc. How will this modernization initiative that we have begun move beyond reporting information about past events? And do you know of any agencies that are using a modernized system?
Thank you, Chair DeLauro. So the first $50 million, the first ever allocation that occurred during last fiscal year, CDC immediately made steps to ensure that the money could go out the door to states, and states received the funds through their epidemiology and laboratory capacity grants, and states immediately began using the funds. And CDC's been working actively on planning efforts to ensure that all of those right pieces are in place for data modernization. The states have been using that money to improve their information systems. Unfortunately, with the pandemic, we were building the plane while we were flying it, essentially. Yeah. And so getting past the pandemic will allow us to more focus on investing in our current systems. While work has been done, it has been delayed because of the pandemic, and so we really need to move this forward. I think the pandemic has put on the spotlight some of the challenges, and that's being put into those plans now.
Thank you. And Ms. Cardenas, let me just, you talked about long-term challenges in the public health workforce. Can you just tick off some of the things that you think that we ought to be trying to do with regard to the workforce and its sustainability and its recruiting?
Yeah, there's any number of aspects of this. One, I'm very concerned about what this workforce is going to look like after the pandemic. You spoke to the aging of our public health workforce. So one, we need to incentivize young individuals going into the public health arena in all different disciplines and areas of expertise, epidemiology, laboratorians, et cetera, as you heard about. Two, we need to invest in competitive salaries. I have a colleague in one of our large metro areas that has lost public health nurses to this pandemic to a for-profit temporary agency because they could pay more doing the exact same work of contact tracing. So we need to make sure that we're investing in good salaries and benefits. The third thing is that we need to remember that oftentimes federal funding comes in buckets or a siloed approach dedicated to specific diseases of the day. We need to get past that and make sure that we are investing in a workforce that supports the functions and the capabilities of a local health department, regardless of what health outcome we're dealing with, because it is the work of epidemiologists, community health workers, health educators, public information officers. That work and expertise is needed regardless of whether you are focusing on chronic disease like heart disease, stroke, mental health, the opioid issues, et cetera. So we have to invest in that type of a workforce and not just a siloed approach that is not sustainable and doesn't build our capacity long term.
Mm-hmm. The use of a federal loan repayment program, does that exist now in your area?
It does not, and that is one thing that I think there are over 100 public health organizations and agencies, including NACCHO, that have signed on to a workforce development bill that would include a loan repayment program for graduates that commit to serving 3 years at either a local, state, or federal health agency. Kind of like the health services, I'm going to forget the name, but I got it here, modeled after the National Health Service Corps. So that could definitely be something that brings a workforce into the local governmental public health sector and state and federal as well.
Mm-hmm. Let me go back to Dr. Turner for 1 second. No, I can't. I have 6 seconds, so I'm going to yield my time and to Congressman Cole.
Madam Chair, you're the chair. You can do whatever you want to do. If you've got another question to ask, please do it.
No, you go ahead. I'll get back. Well, we may not. I just want, if I can, to Dr. Turner. We're talking now about COVID, but just give me a sense of the data modernization as it has to do with foodborne illness and other areas. Congressman Cole mentioned the opioid crisis. There are other areas of chronic diseases. Just talk about the mechanics of this system and how it really is spread over the entire public health area.
Yeah, thank you. The COVID-19 pandemic has highlighted how far behind we are, but frankly, the data modernization initiative is disease agnostic. The infrastructure once in place, it wouldn't matter if it was salmonella or influenza or E. coli or a coronavirus. The systems would work for any infectious disease and for chronic diseases as well. You know, the data could be the systems could be leveraged for data that go into a diabetes registry, for instance, or information about opioid use. If the system is not disease specific, and that's really the key point, is that we need it to be a system in place that is flexible and modular so that we can respond to any public health threat or any event that comes up.
Okay, thank you. And thank you so much, Congressman Cole. Yeah, so I love disease agnostic. I think that's what we're looking for. Congressman Cole.
Thank you very much, Madam Chair. Like you, I'm struck, honestly, by the uniformity of the testimony that we've heard and that I read last night, which actually makes the work of the committee a lot easier. I mean, you all talk about the need for data modernization and exchange and lab modernization. You all talk about the need for workforce development. You all talk about the need for better compensation and better training for that workforce as it comes in. So you've actually made, I think, in some ways, our job a lot easier than it normally is, because we normally have a little bit more diversity or of opinion. And it's interesting to me, you come at this from so many different perspectives, and yet you arrive at the same points. And I was particularly struck, Dr. Shah, by your observation that we maybe overinvest in personal health and underinvest in public health. I thought that was a nice way to actually frame the challenge that we have in front of us. I've got a question, and I'm going to start with Dr. Turner, and I'm just going to ask all of you the same thing, so you can just move right down. I'm curious as to your observation, having, we're still in the midst of coronavirus. What has worked best in the public healthcare system in dealing with this? Where have the biggest shortcomings been, in your professional opinions, in dealing with the current pandemic? So, Dr. Turner, let me just start with you. Tell us what we've done right. Tell us where we need to really improve.
Thank you. So one of the things that, one of the areas we've had great success in over the course of the last year is with electronic case reporting. We've used some of those investments to build that infrastructure, and we have seen 6,800 more facilities come online who are able to send electronic case reports from the electronic health record system to public health. It has made a lot of difference in getting the demographic information and clinical information that's contained in those electronic records, and it really merges well with our electronic laboratory reporting. But we still have a long way to go. It's sort of sporadic, and sort of the bigger clinics have kind of come on board, but as you know, we have a lot of areas across the United States where we don't have these big health systems. I would say that what we have noticed during the pandemic itself is that the data needed to identify vulnerable populations and to really target interventions and target communication and target prevention efforts has not been as robust as it needs to be, because we're just not getting a lot of the information from the clinical visit. And so that is where we need a lot of work, and that is why it's so critical for this data modernization initiative, is so that data is flowing seamlessly between clinical healthcare and public health, so that we have that data really quickly, and we can not only communicate to the public, we can also implement policy changes, we can pivot more easily, and we can target our interventions a lot more efficiently.
Yeah, if we could go to our next witness, please. I think that was Dr. Freeman, or not sure.
Yes, Dr. Bibbs Freeman. So I think that what's worked best for us, I would say, over the last year is our ability to have a wealth of training accessible in a very flexible format. It's been great with communicating new concepts, new principles to our work staff, and being able to offer it to more of our work staff has been instrumental in being able to have us respond to various threats and parts of this pandemic. But I see that moving forward, since we have gotten used to a world in a virtual land, we can apply this moving forward to increase the amount of training that's available to our work staff in a very cost-efficient manner. I would say that what would be our biggest shortcoming, I have to wrap back around to data modernization. A lot of the tools that we want to use to advance public health are really built around the systems that we have to do it. some of the systems need upgrading, and before we can upgrade, we have to do something else first. And before we can do that, we have to do something else first. And it becomes a versioning issue and unable to keep up with it. So you go into a modernization task thinking you're going to update one thing, but then you find out you have to update and address 5. And so you're already behind before you can move forward.
Thank you. Madam Chair, for whatever reason, I'm not seeing my time, so I may be running out of time, and I don't want to overuse it. I know we've got a lot of questions.
Okay, why don't we just try to, get the other 2 witnesses in, and then we will move on. Go ahead.
Okay, thank you. You're very kind to do that. I appreciate that. Dr. Shah, I think you're next.
Thank you, Congressman Cole, for that question. There are a lot of things that obviously my colleagues have already mentioned. I would just say that the fact that our strategy nationally has meant that states and localities have had to work things on their own has been a challenge throughout But the fantastic thing has been just the bringing together of public healthcare and an incredible number of partners. And I will say that another thing that we have to recognize is that the miracle of a vaccine, even that we are a year in and we've got vaccines that are actually protecting human beings today, is incredible. And now our job is going to be to get as many people vaccinated as quickly and equitably as possible.
Yeah, I'm very struck by the same fact. I actually thought that's where we've done the best. Maybe if we'd had a more robust system, we could have slowed it along, and done a lot better initially, saved a lot more lives just by the speed of the vaccine. And I think Dr. Cardenas, you were next, and I'm sorry, I sort of jumped the line there. I apologize, but very much interested in your thoughts as well.
No problem. I never mind yielding to Umair. So I think we really appreciated that Congress acted early and quickly last March in issuing some emergency appropriations and allocation. I think one of the things that hasn't worked so well in this, I think there's work that can be done at the federal level, is ensuring that this money flows equitably right down to the local level. In Connecticut, I can tell you I've received $176,000 in federal pass-through dollars from my state. $176,000. So that's not the case across the board. Some states are doing this very well. I think the other thing is we've suffered at least a little bit early on from kind of the lack of a national plan that's really been informed by local and state perspectives and expertise. We know our communities best. We know our partners best. We've been practicing for this. And I think this has included vaccine administration. I mean, we're doing a yeoman's job with little or no resources, but we should have been investing in as much in the vaccine administration capability as we were in the development of the vaccine itself.
Thank you very much. And Madam Chair, thank you for the extra time. I appreciate it. Yield back.
Thank you. Congresswoman Roybal-Allard.
So, Dr. Cardenas, I'd like to go back to the issue of the public health workforce. As much as we would love to provide all the resources that you need, the fact is that there's always limits to our funding. So how would you prioritize the public health programs, and at what level of investment do you think is needed to train and to sustain a public health workforce that will be adequate to meet the needs of the next 20 to 30 years?
Sure. So, as has been commented, state, federal, and local partners in public health have been working on what it would take to modernize our public health system and what that looks like for a long time. There has been a proposal of $4.5 billion annually to build and support a robust public health system at all levels. I don't know if that's the perfect number, but that's one that has been grounded in evaluation of what does it take at the local, state, and federal level to respond appropriately and to protect our communities. So I think that's a good start. It's grounded in public health science and information about what we know it takes to protect our communities. The fact that we need data systems and modernization, the fact that we need epidemiologists and all of these other disciplines, as I said, whether we're talking about dealing with chronic illnesses or a public health emergency. So I think that, you know, I'd also like to flip it around and think about what is the cost, the ongoing cost of not investing in these things. We're about prevention. I think you could probably not identify a discipline where the return on investment could be greater. We are talking about extending lives, improving quality of life, improving the resilience and the health of our communities. Those are some comments and thoughts there.
Okay. Dr. Bibbs Freeman, as been mentioned, one of the critical components of public health infrastructure is a laboratory capacity. And one of my legislative priorities has been newborn screening, and we are currently working to reauthorize the law that provides federal support through the CDC and HRSA for state newborn screening programs, which can save babies' lives and prevent them from suffering from disability genetic diseases. It has been brought to my attention that the COVID pandemic response has created shortages in the availability of the plastic material that is necessary for carrying out the newborn screening test. Can you tell us how the Virginia newborn screening program is being affected by the pandemic response? And is there a long-term solution to prevent shortages such as this from impacting other critical laboratory tests?
Yes, thank you for your question. And so I would definitely say that the availability of supplies, materials, and plastics, as you have indicated, have not only been an issue for newborn screening, but it's become an issue ubiquitous within our laboratory. All of the vendor systems and manufacturing systems have been reprioritized to sell to COVID-related functions only. Because of this, we've had delayed deliveries, able in some cases to had to delay it. Time critical functions delays. Another thing that contingency plans and continuity plans previously.
I think we lost her.
Yeah, just right at the end, I think, Lucille. We can get
right. Okay, we can get the rest of the testimony.
Okay, thank you very much. Congressman Harris?
Yeah, thank you very much, and thank you all. You know, just this week I was speaking with one of the health officers in one of my counties, one of the largest counties in the district, and he was talking about the difficulty in fully staffing the department. So he had brought up you know, what last Congress was HR 6578, the Workforce Loan Repayment Act. But I had some questions, and I'm sure many of the panelists have thought about this act. So at many different levels, we have a workforce who's also trained in public health. Other workers who don't have that much, was kind of one size fits all, and I'm not sure. And so, first of all, let me know, is that true? Was the bill last year written as a kind of one size fits all, you know, up to $35,000, not depending on how many loans you have? And second of all, where is the distribution of need within the professional levels of the public health services and the public health departments throughout the country? So if we can start there, that'd be great. And anyone?
Yeah, this is Umair Shah. I'll start, and I don't have enough on the specific bill, but let me just answer your second question, which I think is a critical one. I do think it's in all levels of the workforce within the public health workforce. Now, as you know, that with physicians, sometimes it's the incentivization of physicians so that they're not going into the specialties and they're going to primary care. But then, you know, another sub-primary care or another specialty is public health and prevention. It's a very different field than, you know, being a primary care doc, which I've been before. It's actually being in public health departments. And as you know, that's a different area that not a lot of physicians have been exposed to. But then you can go down the list of nurses, you can go down the list of those with other kinds of loans for masters in public health, or other kinds of, even now, bachelorette programs in public health, where everywhere the workforce needs support. So even though a physician or one of the higher paying fields may get more of those dollars, and then we have to try to figure out how to incentivize them to look at the field. We also have another issue, the conundrum of other professionals who are going into the field who still, for their income level and for those dollars, especially for people who are coming from disproportionately impacted communities, when we say we want our workforce to be diverse, we want to make sure we're doing everything we can to give them the opportunity to be able to not just pay back their loans, but to support them as they're doing good public health or public sector work.
Let me follow up on that. But if you look at the workforce needs, I mean, is there an absolute need for, because this loan repayment program is structured after the public health service loan repayment, which is specifically targeted to, as you suggest, primary care providers, people who go into rural communities, places where you can't. This is a little bit different because a lot of these public health departments, for instance, are not in rural communities. I mean, I represent a rural district. I imagine my rural district is much more difficult to recruit someone into than in the Baltimore, Washington parts of my state. So, how difficult is it to recruit physicians into the public health field?
It is very difficult. I'll tell you, I've spent a whole career trying to get physicians into public health. It is extremely difficult. I mean, the fact that first of all, there's not a recognition of the value proposition of what public health brings. Why should I be looking at this field? There's not exposure in medical education and residency programs. You always know, when you're a resident, there, even a student, you see an intern, a resident, a fellow, and attending, and you know exactly a pathway. In public health, it is a completely nebulous pathway, and so many people get there in different ways. And so I do think it's very difficult to get physicians into public health. It's not impossible, though, because there are many mission-minded and service-minded individuals, but we need to get them exposed, and then we also have to do what we can to support them as they're making career choices, and that's the incentivization. Whether it's an urban area, a rural area, we know we've got to do a lot more so that they are exposed and that we can get them to retain their activities within those areas and those departments.
Thank you very, very much. I yield back.
Thank you. Congresswoman Lee.
Thank you very much, Madam Chair, and thank all of our witnesses for being here. Let me just preface my question by this. Public health infrastructure and increasing support is something that I always believe we must do, but we cannot increase support in the public health infrastructure as it is, because of, for the majority of people of color, systemic racism is part of that infrastructure. So I hope we're seeing building this support for public health infrastructure as a way to dismantle those policies that have created such disproportionate impacts of diseases on people of color. And so, of course, I'm working on my anti-racism and public health bill, but I wanted to make sure that we understand a couple of things about the public health infrastructure as it is. First of all, just in terms of the data, 78% of Americans over 65 are white. The life expectancy of African-American men is 68. That was last year. It's down now again, okay? When we look at the Asian American, Native Hawaiians, Pacific Islanders, they're often labeled as other. And so we don't even acknowledge race and ethnicity among our AAPI communities. And so there's so much in our public health infrastructure that needs to just be totally dismantled. And so I'm wondering how you all address systemic racism and structural racism, which we know have negative outcomes for people of color. Dr. Shah, would you like to first respond?
Yes, Congressman Lee, thank you, first of all, for your leadership on this issue. I've watched it over the years. I will say a few things. And in Harris County, my previous position, we actually, our elected officials, called out racism as a public health issue. And Governor Inslee at the state of Washington is also very much of that same mindset. And this is a really important issue because it's one thing to talk about diversity and equity and inclusiveness. It's another thing to enact it. And it's really not about theory, it is about practice. And when we are looking at our own workforce, we've got to be intentional on who comes in and how we represent the entirety of that community. As you say, I'm a proud Asian American. I will tell you that this is an incredibly difficult area in public health, but at the same time, we also have to recognize the very champions and those messengers for the messages that we are trying to enact in many, 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 many communities who mistrust, distrust, and do not even believe that many of the things that we're doing or don't have the information is the right thing to do. So promotoras and people who are of that community are the best ways to be able to promote that diversity. But if you don't have a diverse workforce, then you're starting all over, and then that mistrust, distrust rears its ugly head.
Sure. Anyone else would Dr. Freeman, would you respond? Because I know that in California, for example, less than 14% of practicing physicians in our state, California, are people of color, physicians of color. But again, there's some systemic issues, some structural issues in our public health system that need to be unraveled first before we can just, quote, build it back moving forward.
Yes, ma'am. So I think a few things, and I think I will try to reserve my comments to the public health laboratory space where I work in primarily. So through my partnership with the Association of Public Health Laboratories, I am the chairman of the Diversity, Equity, and Inclusion Task Force. And I feel very strongly that in order to move to a situation where we are as diverse as we possibly could be, we have to first understand where we are. I am not sure that the attention that it deserves has been given to assessing at a baseline level the diversity within an organization, within a laboratory space. And so our task force is working very hard to identify how we want to operate, kind of clarify what diversity and define what diversity means to us. But in doing that, in our member laboratories, we're hoping to do diversity surveys so that we know where we're starting with and where we have to go to. And then we look to build toolkits that are associated with training laboratories, training professionals, and training leaders on how to increase the diversity within their own laboratories. In addition to that, the diversity really isn't enough. We also still have to be sure that people feel included in the space that they're in and that they have the tools necessary to be successful. I really think that it all goes down to seeing where we actually are. And I think that I'd like to just end with, in building trusting communities, as Dr. Shah mentioned, people want to see employees that are working for them that look like them, that represent what their communities look like. And that's a first step into building trust in public health.
Okay, thank you very much, Madam Chair. And Madam Chair, can I just say, I hope we have a hearing or can do something as it relates to the structural issues that are really have really prevented the whole effort toward making sure that health outcomes for people of color are what they should be within our public health system, because structurally we can't move forward until we dismantle those old policies and structures.
Okay, thank you.
Thank you.
We'll do it. Congressman Fleischman.
Thank you, Madam Chair and Ranking Member Cole. I really appreciate the bipartisan tenor of this entire hearing. Thank you so much on this very important issue. And for all the witnesses, all of your testimonies have been so helpful and insightful. So I want to address my questions to all of you all, and please just take them in order, and we'll just do that until we run out of time. Effective vaccine distribution plays a vital role in eventually getting back to some sense of normalcy. Unfortunately, the digital infrastructure used to schedule vaccine appointments has created significant obstacles for those without certain technical resources. First, I have 3 questions. What offline avenues can we take to ensure vulnerable populations have equal access to the vaccine? Second, essential workers often have schedules that extend outside the regular 9 to 5 working hours. How can we provide viable opportunities for those individuals to receive the vaccine? And thirdly, we're seeing some cases where individuals in rural areas are being forced to travel long distances in order to reach a vaccine site. Although large-scale vaccine sites work well in urban areas, how can we better balance distribution to our rural communities? And I will rest and then let all four witnesses respond, please, Madam Chair.
Thank you. This is Dr. Turner. I think that what we need, first of all, we cannot do outreach and we cannot target interventions and we cannot target efforts unless we have data with which to do that. And so building the public health data infrastructure gets us the data we need to target those interventions, including vaccination clinics. If it's not a disease-specific system, then we can use the data that we're getting on all diseases and identify those vulnerable populations. We might have data on lead or hepatitis or the opioid crisis, regardless of what types of data, the reason for looking at the data, as long as we have the systems that have those data in them, public health is in a better position to be able to target interventions such as vaccination clinics. There's no doubt that our immunization systems need to be interoperable with healthcare and public health. I think that effort will require its own dedicated resources outside of the data modernization initiative, which has those 5 pillars. But the data modernization initiative can be leveraged to assist in those efforts.
Thank you.
To address your first question in regards to offline avenues for equal access, I think one of the things that we skipped in the vaccine distribution scheme was that we usually market that this is coming, and we work very hard over time to build trust. But the truth of the matter with COVID-19 was we didn't have that time. And so a lot of times in building trust, you have to go and be ready to partner and speak with local communities. Because we skipped over the marketing to the local communities and engaging community leaders, we're at a disadvantage to getting vaccine to the areas that are being more affected. And so I think that it's time for us to possibly relook at those partnerships that we had before with community leaders to be sure that we're making sure that avenues are available for equal access to the vaccine. In addition to long distances to reach vaccine sites, I would propose that we look at more mobile vaccine clinic strategies. We have been able to mobilize testing in a number of ways, and it's been highly effective in reaching the areas that do not have as much access as other more urban areas. And so I do think that that's something we could definitely look at. It will require that we have appropriate storage and refrigeration and handling, but I think that's something that we can figure out fairly easily.
Thank you so much. And would either Ms. Cardenas or Dr. Shah like to respond in the remaining time we've got?
Yeah, I'd love to, because I think that you've asked questions that really highlight the strength and the value of local governmental public health. We know our communities best. We have had to develop significant workarounds for populations that couldn't access the VAM system or figure out how to register. We know our partners locally. We've engaged, senior centers and social service departments and our town municipal officials to support us in that effort to make sure that it was accessible. With respect to essential workers, you're absolutely right. But at the local level, we have a good sense of when and how those clinics need to be operated, what resources we can bring to bear. Rural areas are particularly challenging, and we're hearing about that from my NACHO colleagues that are struggling with this right now.
Thank you. So
add is that from the state of Washington standpoint, I'm really excited about 2 initiatives that's in my testimony. One is called the VAX, the other is called the VIX. The Vaccine Action Command and Coordination System, which is bringing public-private partnerships. So we have Microsoft and Starbucks and Costco and others that are at the table that are helping us really harness the power of the public-private partnership so we can improve the experience of the end user, the individual, the Washingtonian. While we're also have the VIX, which is the Vaccine Implementation Collaboratives. It's really designed for equity feedback dialogue. And so the VAX on the one hand is about throughput and numbers, and the VIX is about equity and making sure we're doing things equitably. I don't think it's, I think a lot of people in the vaccine world think that it's a false dichotomy, that for some reason that you can't do both, that you can't vaccinate quickly and you can't vaccinate equitably. I believe you can do both. It's just that we've got to make sure that we're complementary and intentional in how we go about doing that vaccine effort. So, Congressman, those are two efforts that are very much about what we really need to be doing is, at the end of the day, prioritizing public health and prioritizing working with our partners, such as what Jennifer just mentioned with our local partners, and frankly, all sorts of other partners across the table that can help us, because they have a lot of incredible know-how, but we in public sector oftentimes are not able, willing, or develop the systems so that they can actually be a part of the solution. And so I just wanted to point that out as well. Thank you.
Well, thank you.
Congressman Pocan.
Thank you, Madam Chair, and thanks to all the witnesses for being here today. There's two different areas I'd like to try to get questions in on contact tracing and on vaccine hurdles. Let me start with contact tracing. I don't know if Dr. Turner, you might be the most appropriate person, or if anyone else is, please feel free to answer. We've been told the mantra was testing, tracing, isolation for a very long time. In my state of Wisconsin, we've largely had local units of government doing the contact tracing as opposed to the state. There's only a few hundred contact tracers at the entire state level. And when we hit our peaks, we probably were only tracing 1 out of 5 people, maybe, last fall, with some really tough numbers. Have there been any policy recommendations or personnel changes in contact tracing? And would any different increased or sustained funding in this area be helpful? Our problem really has been in retention also. It's been a little bit difficult to attract, extremely difficult to retain contact tracers. Wondering your experiences.
Yeah, thank you. You probably already know this, but we've been doing contact tracing in public health for 100 years. So it wasn't anything new. We already know how to do it. But one of the key elements for the COVID-19 outbreak has been robust contact tracing. What we have found is that phone numbers, contact information is missing in over half of the lab reports that are sent to public health authorities across the nation. So the contact tracers have to figure out how to even get a hold of people who have a positive result first. It makes the job incredibly difficult. And when they are doing the contact tracing, you're absolutely right. They're running into roadblocks. People don't want to talk to them. And that has to do with trust and what's happening with their data. Who's getting access to my information? Who are you sharing it with? And that sort of thing. So that's all kind of part of the whole topic of making sure that we have data systems that will talk to each other, and making sure that we have data systems that are secure, and that the public has trust in public health keeping their data private and confidential. And so it's all part of the sort of that data, the data focus. You can't contact people if you don't have contact information. So that's the importance of being able to have our systems interoperable. Did I answer your entire question?
Yeah, you did. I think it really does come a lot to the data collection side of things that we've been lacking. So the second question is on vaccine hurdles. So one of my concerns is that, just personal opinion, that we're going to get to 50 to 60% of people relatively easy. I think we're going to have struggled to get to 70 to 75% of people. I actually think we should be doing advertising and things right now, even though there's not the supply issue yet. I think you need to build the demand question. But one of the concerns I had is one of the largest vaccination sites in the country in Los Angeles recently was closed down by anti-vax protesters because of what Facebook as a platform did. We've written to them. They have not replied back, although I saw recently Facebook's ad policies are going to block messages from cities, healthcare providers, and community and faith-based organizations promoting COVID vaccines, which gives me great concern. Are you seeing disinformation becoming a problem yet on vaccinations? Because again, my real concern is that gap we're going to get to between 50 and 60% and the 70 to 80%.
Yeah, Congressman, this is Umair Shah, I'll take that on very quickly. I say yes, we are, and I think you're absolutely right that right now, for every vaccine you have 10 people ready to get in the chair to get it. So it's a supply demand issue right now that's flipped in the way that supply constraints are really masking this issue that is going to be coming. You are right, in my opinion as well, that later on and not that much later on, by the way, sooner than later, we're going to have this real issue around people hesitating because of misinformation, disinformation, mistrust, distrust, or frankly, wrong information that is going to be driving decisions. And unfortunately, it's happening even in the healthcare system where we're having healthcare workers who honestly, we would hope would not hesitate because they've seen up close what's happening with COVID-19, how devastating it can be. And they're also having questions. And I've gotten the vaccine. I've gotten 2 doses. My 83-year-old mother has gotten her 2 doses. I will tell you that we have to do everything we can to not just be about the science, which is where it starts, but we've got to be markedly better about the engagement, and so that we communicate to our communities so they trust us and they trust the science.
Thank you. I yield back, Madam Chair.
Thank you. Congressman Klein.
Thank you, Madam Chair, for holding this important hearing. Ranking Member Cole, members of the subcommittee, and witnesses, thank you for being here. As we've seen, states within the U.S. have been impacted differently by this virus and have also responded differently to it. Further, states' ability to curb the spread has also varied. Their responses to this pandemic were first made noticeable by the availability and access to timely testing. Now, response is also being measured through the efficiency of vaccine distribution. Both the national and state public health infrastructure is being put to the test as they have scaled up to mitigate the effects of the COVID-19 pandemic. Unfortunately, in late January, my state of Virginia was ranked 41st out of states for vaccine distribution by state population. Thankfully, in the last few weeks, much progress has been made, bringing Virginia up to 22nd percent of the population that has received the first dose of the vaccine, with it totaling 14% of its population. Virginia is currently 2% away from vaccinating the maximum percent of the population for which we have vaccines allocated. And it's vital for Virginia to keep on the trajectory it currently is with regards to vaccination and testing. But unfortunately, the slow start definitely hurt us. And when we were ranked last at one point, not only in testing, but at one point we were ranked last in vaccine distribution, that is cause for concern. So let me ask Dr. Bibbs Freeman, in a teletown hall I held last night, I heard from many constituents who were frustrated with Virginia having one of the slowest rollouts for the vaccine. Many Virginians were frustrated not only with the lack of access initially, but also the lack of information available. Thankfully, Virginia's made substantial progress. And while I understand you're in the Department of General Services Division of Consolidated Lab Services, may not have been directly working on this, you spoke to it. Since you're still with Governor Northam, can you please speak to some of the reasons for the delays that Virginia had with getting the initial groups the vaccine?
As you indicated, my knowledge of the vaccine program in Virginia is very minimal, but I can say that I would like to kind of wrap back around to data modernization. I understand that there were a number of issues related to registration and pre-registration of citizens into the systems that were available. Because there were multiple systems that were available to the public at different times, there was confusion created in the population. And as you well know, when things don't operate seamlessly, you begin to lose citizens who are willing to be vaccinated, and that's a concern. Based on the information I know, things are being handled way more efficiently. The current system registers citizens more seamlessly. I think the thing that is most concerning, based on the feedback that I've heard from the citizens around me and not necessarily the Department of Health, is the slowness with which they are being contacted to be scheduled for their vaccine. So while they are pre-registered now, there is a slowness associated with callbacks to go and actually receive the vaccine. I do think that it would be worthwhile to let the citizens know that we are vaccinating at the levels that we have available. What we have here is a supply issue. there is not enough supply to vaccinate all of the people that we would like to. And until that supply becomes available, we'll be unable to do so. But I think that the system now we have available can register the citizens. We also have a system to vaccinate the citizens, but what we need is the actual vaccine.
And you mentioned this in response to another answer to a question. As you know, we're blessed with many rural communities in the state, but many in the communities, many of which are in my district, have issues with access to healthcare in general, but specifically to the vaccine. You mentioned the idea of mobile vaccination, and I think that's an excellent suggestion. I would hope that we could pursue that further, and strengthening infrastructure in these areas, both through retention of medical personnel and through avenues for care. And can you expand further on what might be necessary to make these mobile vaccination opportunities a reality?
Absolutely. So I think the first thing we actually need is actually a mobile device of some sort, a van, a truck, where we can actually mobilize. So one of the things that some of our partners, and I'll reference the Fairfax County Public Health Laboratory, they had a mobile system, but it was not enough to cover all of the areas that they would like to use it in within Fairfax, and I think the same exists. We need to possibly look at creating a fleet that can be easily mobilized for these purposes for not only this event, but future events as well. In addition to that, we will need storage. A lot of the vaccine that we have available has some very stringent storage requirements, and so we'll have to work out exactly how that occurs. But to kind of push back to workforce a little bit, you will need people to coordinate the mobilization clinics. You will need people to register as well, and one person on a mobile van can't handle all of those pieces and parts. And so we're going to have to look at creating systems that will support not only the registration and the distribution, but we also need to look at systems that will handle the coordination and the actual vaccination process in a safe manner.
Thank you very much. I just want to also add, you got a beautiful building there on that poster behind you. Is that the building is that a new building in Richmond?
That is our building that we built in the early 2000s that we are currently housed in now.
Where is that?
It's in Jackson Ward in Richmond, Virginia.
Awesome. Thank you, Madam Chair, for humoring me for a couple seconds, and thank you for those answers. I yield back.
Thank you. Congresswoman Frankel.
Hello, everybody. Thank you to the panel. I have a couple of questions. I just to follow up this in terms of registration. I would say probably one of the most frustrating, confusing parts of trying to get a vaccine, at least where I am, is for people to sign up for the vaccine. There's been a lot of different systems. In the early days, a lot of the systems crashed. The people who don't have computers were not able to even sign up. If you could just comment on that, is that part of your responsibility to try to get these registration systems up and running well?
This is Jennifer. I'd be happy to share what's happening in Connecticut. So, you know, there are a lot of moving parts, and we do need a federal mechanism to monitor and track vaccine and first dose and second dose and allocations and that sort of thing. So I appreciate all of that. But for the recipient, the end user, we have not taken them into account when we developed this vaccine administration management system and the need to register through it. It's been very cumbersome. In my jurisdiction in particular, as the rollout started for beyond first responders to population 75 and older, we had to abandon that system for them. We still use it, but we had to engage the people that they're used to working with, their senior centers, their municipal partners, so they could simply pick up the phone and make an appointment. And then we worked with those agencies to capture the data we needed. But then this required a lot of back-end data entry on our part, but it was a necessity if we were really going to reach those vulnerable populations. Many of my colleagues across the country are working on similar workarounds. health systems that have electronic medical records, I think, have an easier way of doing this, but the majority of local health departments, one, don't have a mechanism to bill for administration of this vaccine and or to use those electronic medical records. So it's taken additional resources, but that's the work that is our responsibility as we work to get vaccine into people's arms.
Well, thank you for that. Madam Chair, I think we don't have anybody, I think from the federal agency on today, but I do think that the situation which I described and our presenter described is very common probably across the country. And I think there needs to be some federal response to this.
Well, just for 1 second. Yesterday we did, and with the roundtable, we did with Dr. Walensky, Dr. Shukit, and Messonnier in terms of the federal piece. But you're right in terms of suing where that needs to go for that.
Yeah, but I think just in terms of this whole register, people registering for the vaccine, it's been a mess. Okay, I got another. Do I have myself?
Yes, no, go ahead.
Okay. On the issue of the disparity in the salaries, could somebody give me an example of what the public health nurse is earning versus someone in the private sector, and also in terms of benefits?
I mean, Umair can probably speak to this as well, and of course, it as you well know, depends on where you live in this country. In Connecticut, a public health nurse working in a local health department might make, $65,000, $70,000 a year. It used to be when you worked in the governmental sector, because I've worked at the state governmental level as well, that we offset lower salaries by richer benefits, but that has diminished over time. So, the benefits are not as rich anymore in the public sector. A private nurse, working in a hospital or doing comparable work for a temp agency probably can make $10,000, $20,000 a year more. And I would look to NACHO. We may have additional data on this, as many of our members, as I spoke to earlier, have struggled with this, actually losing their public health nurses into other agencies.
Thank you.
Also seen, Congresswoman, is that epidemiologists, for example, will get recruited by hospitals to be infection control practitioners because they see them as being good at disease control, better sometimes than nurses. And so you now have, it's not just nurse going to nurse, it's an epidemiologist going to a completely different position that pays higher in that private sector model. So I think that's another piece that needs to be looked at.
Thank you, Madam Chair.
Congresswoman Herrera Butler.
Thank you, Madam Chair. And I'm going to ask a similarly more state-specific question of Dr. Shah, as Mr. Klein kind of did. I recently saw a report in the Columbia newspaper, which is our biggest paper of record, that showed that Clark County, the 5th largest county in Washington state, is being shorted vaccines by the state, which explains a baffling low vaccine administration rate in Clark. More specifically, Clark County has received 94 doses per 1,000 people, whereas like Spokane County has received 145 doses per 1,000. Snohomish has received 121 doses per 1,000. Pierce has received 111 doses per 1,000, and King has received 132 doses per 1,000. And according to public health data analysis of the 5 counties with the highest, lowest, and medium population sizes, Clark ranks 14th out of 15 counties for first dose allocations. And honestly, this is just unacceptable. It's absolutely unacceptable, and clearly shows that the current allocation metrics that public health is using are not creating equity, but instead causing Clark County to have this weird lottery-like system for people who are eligible. I hear all these people talking about what we're going to do to convince people to take vaccines, and I'm like, wait, I got eligible people in 1A population who cannot get their vaccine. We've heard repeatedly that this is a supply issue, but given this revelation, I think it points to a systemic issue in how the state chooses to allocate the vaccine. And I need to know what what your department is doing to rectify this error and why Clark is being shorted vaccines compared to the other 4 largest counties. I similarly want to put Lewis County on your radar for the same exact reasons. The older population is not receiving an adequate amount of vaccine. Lewis is in the last place for vaccine distribution, but has the highest population of elderly residents at 21%. And all my counties are on I-5. We're in distribution corridors. I just wanted to see if you could speak to that.
Yeah, thank you, Dr. Herrera,
Hey.
Congressman Herrera Butler. It's great to see you by camera, and I hope to be able to see you in person soon. So thank you for your leadership, and thank you for that question. And you know, the reality is that we January 3rd we were at 29%. Of every vaccine that was coming into the state that was being administered. We're now well over 85. Actually, we're at 90+% right now, although it's some of that is impacted by the weather. So it's gonna probably be dancing between that 80, 85, 90% for the next several days to week. This is absolutely, I've seen that article, and I will say that we had already been reaching out to the jurisdictions where we had seen decreases or not as much of the supply even prior to this. This was actually over the weekend, and Lewis County was one of those. So I just wanted to make sure you were aware of that. One of the real challenges has been that, you know, as we were starting with 1A, we were going with hospitals and healthcare systems, and then we were pivoting to those jurisdictions and obviously with community providers and pharmacies, et cetera, looking at a number of factors, including the pro rata in terms of what was going into those counties and data from the providers who were actually asking for the vaccine, the populations that they were willing and able to vaccinate, which included the equity piece that you had referred to, and then information on really their throughput and their ability to vaccinate. The reality is that when you take all that together, it is absolutely imperfect when it comes to jurisdictions. And so what we're now doing is going back to the ones that have the most the gap, if you will, and trying to figure out what we can do. The other piece is that we had more Pfizer vaccine, so it said, okay, well, let's move Pfizer vaccine there. And then some of the providers said, well, we don't have the capability because of the storage requirements with the Pfizer vaccine. So there are a lot of these factors that are not excuses, by the way, but explanations. But what we need to do is continue to do a better job of working with the local health jurisdiction. And because I've been at that local level for 17 years, I tell you that it is something that is key for me. But right now we've got a lot of these moving pieces that need to be addressed as we work with our local partners.
I appreciate that, and I appreciate your attention to this. I understand, so one of my challenges has been, you know, as we set up these mass vaccine sites, which is great. Oops, doggone it, I just lost you all. There you are. Okay, so I'm trying to click to my next thing. What we saw was we had providers, we had small pharmacies, we had who were already set up to, my office has helped them get set up to administer vaccines. And when you set up the mass sites, those vaccines got pulled from them. And so, yes, the number went from 30% to 80% or higher because you got the shots in the arm, but
I think I lost you.
Okay. Okay. I think we will.
Madam Chair, I did
follow up with Congresswoman Herrera Butler here. Okay. I can't hear you now. Okay, now I can. Let me move to Congressman Harder. No, I'm sorry, Congresswoman Bustos. I apologize. Congresswoman Bustos.
Thank you, Madam Chair. I appreciate it.
I'm sorry.
No, that's all right. That's all right. You got it right. And Josh was right ready to get in there.
Okay.
I want to share a story. This is just fresh off of a phone call I had yesterday with the Henderson County Health Department leadership. Henderson County is a county in my congressional district in Western Illinois, the smallest county in my district by population, 6,500 people, but it's 400 square miles. And if you do that math real quickly, we're talking about 17 people per square mile. Let me tell you a little bit about the challenges that they've had with the COVID vaccination. They had all of 2 phone lines throughout the whole health department where they could take appointments. That's it. There were no online options because this is a rural county. Many people do not have broadband. So they don't have the infrastructure even to set up an appointment. So they got a little more money. So now they have 4 phone lines. And they've got a total of, for this entire county, 11 staff. They do have a volunteer corps where it seems like the average age is somewhere around 80 years old of the volunteer corps. They want to provide mobile vaccine clinics in their communities, but they don't have the staff to do it. They don't have the volunteers really who can go out and do that. And I share that with you as just one story, but really something like this is all too common in rural America. And despite all of Congress's support through COVID relief, we clearly need to do more and find new ways to support these kind of communities that are smaller and more rural. So here's my question. Other than mobile units, have you seen any innovative ideas or best practices in other rural communities that we can share and help some of the smaller counties, not just in my congressional district, but all over the country, where they can stand up more vaccine sites and make vaccine appointments that are more accessible? If we can start there, and I welcome anybody to answer that question.
Go ahead.
No, I would just comment that NACCHO is an incredible resource for model practices of this type. And so I would ask the NACCHO staff to provide you with whatever they've learned, because you're right, these are issues that we're seeing across local health departments serving our rural communities. And one of the strengths of NACCHO is really sharing those best practices so they can be replicated. So we'll get back to you on that.
Yeah, and I would actually similarly, ASTHO has, from across the states, a number of different models that also would be of use, and our staff at ASTHO can also get that information to you. Just as an aside, 2 weeks ago, I was able to go to Spokane on the eastern side of Washington, and then down to the Tri-Cities area, which is southeast Washington, and then to Yakima, and then coming over the Cascade Mountains back into the Seattle Olympia area. And I think you're absolutely right that what's happening in rural areas, and NACCHO represents the vast majority, Jennifer will attest to, our rural, frontier, and smaller jurisdictions, that the themes may be similar, but the solutions and the real how to bring people together have to be very methodical and intentional. And one thing that I saw was very successful was the use of the pharmacy partners. Pharmacies within those smaller jurisdictions still are very good partners, and they are absolutely able to do appointments and do all sorts of things. So I do think that that is another, a practice that we should also be thinking about, is how do we look at those partners that are already on the ground and really help support them, which is obviously the role of states. But when Jennifer speaks of what NACCHO and the local health jurisdictions do, that's absolutely what we have to do, is working federal, state, local, all throughout the system with our partners.
And are there other partner organizations that you've seen specific to the rural areas that we might want to explore in addition to the pharmacists and the pharmacies?
Yeah, well, so as Congresswoman Butler had brought up at the very end there, is that we're also, I think the states can also be, as well as locals, be very intentional about mass vaccination sites, because that, I think, is also helpful in the rural areas. We also have to be thinking, as the news came out this morning about the J&J vaccine, the Johnson & Johnson vaccine, because of the one dose, that may also, we've asked and this is something very important, our federal partners to give us guidance on where the best setting and best use, best population to be able to use that vaccine, because it's a one-dose vaccine. And so in rural areas, it may make sense that would be a vaccine that would be optimized. So anyway, there are a lot of these issues with ag workers and those who are migrant farm workers that we have to really be addressing, as well as the partners that are already in those areas.
Very good. Madam Chair, my time is out. I yield back. Thank you
I would just want to say is, if we can get those documents from NACCHO and from ASTHO, et cetera, on work in the rural areas, I think it would be critically important to our entire, to every member, and what we may try to deal with in terms of best practices. So if you can get that material, we will get it out far and wide to the not only the subcommittee but beyond. Okay.
Thank you, Madam Chair.
Thanks, Congressman Harder.
Wonderful. Well, thank you, Madam Chair, and thank you so much to all of our speakers and guests, and thank you for the work that you're all doing on the front lines during this public health crisis and well before. I've seen in my district our 2 public health officers in our 2 counties that have really gone above and beyond over the past year, but unfortunately they've come under a lot of stress and attacks at the same time. I think this has happened across the country. Many of our local public health officers have received death threats just because they're doing their job. And of course, we've also spoken about vaccine hesitancy as well. And it strikes me that one of the costs of this pandemic is a loss of faith in our public health system, at least to some degree. And so I'd really love to hear from folks working on the front lines. How do we restore confidence and trust in our public health system, especially because so much of the work that you all do at the population level really relies on that confidence that we really, it seems, need to do a little bit of work to shore up and rebuild. So would love to hear from anybody if they have ideas about what we could be doing there. Thank you.
I would just start by saying thank you for that question. I would start by saying it really is all of us, including our elected officials, to help us. Federal, state, and local health officials across the country have been vilified in this process. And whatever you all can help us do, because of the incredible reach you have in across the country in your jurisdictions, your congressional districts, to help support public health officials in the work that they're doing, I think that's absolutely critical. We cannot politicize public health, and unfortunately that's what's occurred, and that vilification then leads to exactly what you said. So this is a real concern. And so when I talked about supporting the public health workforce, that's what I meant. It wasn't just about putting dollars there, but it's also really truly supporting the frontline people. They are truly heroes as well, and unfortunately we're not always addressing them in that manner.
Yeah, this is Jennifer. I mean, I know as a public health professional, we watched with, great dismay, the loss of some of our public health leaders at both the state and local level because of the politicization. That's a tough word. I can tell you that the one thing that continues to fill my bucket every day is the partnerships that we have had the opportunity to build and strengthen through this pandemic, despite the fact that we're under-resourced, we're overworked. And I am just hoping that through this, and when we get through this, we will continue to be able to build those partnerships, be that with our first responders, our emergency managers, our town officials, our school superintendents, our business partners. They are recognizing the value and the importance of the work that we do. We need the support of people like you to invest in us, to demonstrate the value that you place in public health. And I think those things can go a long way in moving us past the victimization of our public health leaders that has occurred.
Thank you. Thank you.
Congressman Harder,
go for it.
Could I also respond to that question? I think part of restoring confidence as well is appropriate messaging in a culturally relevant way, being sure that we can understand what's being given out to the citizens. In addition, improving the access to that messaging. But I think we need to communicate our wins just as loudly as our failures are being communicated. And I think in public health, we just kind of push forward and we do the work and we worry about everything else last. But I think we have to be dedicated to communicating our wins just as loudly as our failures are being communicated.
Absolutely. Thank you. One other quick question. We've talked a lot about the challenge of really getting public health workers, especially in more rural areas like my district. I'm very interested in the role of the U.S. Public Health Service and trying to embed folks from the CDC. I think that could be an interesting opportunity here. Have any of our guests had experience with the Public Health Service Corps, and do you think there are opportunities there to plug in some of these gaps that we've talked about today?
Yeah, Representative Harder, this is Kathy Turner. We actually have a long history in Idaho of working with the Public Health Service and having career epidemiology field officers as well as epidemic intelligence service officers assigned to Idaho. It has been, workforce development is one of my passions, and so it starts at the local level. Support for these people because they're in training. A lot of them are being trained to do something else. I think one of the great benefits of the Public Health Service and the EIS service in particular is these folks get to be stationed in a state or local public health agency. They may go on to a federal agency, but they have experience and they know the experience of the local and state level. And they can speak to the importance of some of the challenges that we've been talking about today, like, data flow and the importance of infrastructure.
Thank you. I yield back. Thank you, Madam Chair.
Yes, Congresswoman Clark.
Oh, thank you so much, Madam Chair, and thank you to all our panelists, excuse me, and witnesses today for this really important discussion. There has been so much loss in our country and so much frustration about the rollout of vaccinations once we had this incredible product, life-saving vaccination in hand. How do we get it into arms quickly and equitably? And so as we look at the role of data and the importance of that to our infrastructure, I had a question maybe for Drs. Turner and Bibbs Freeman. The variants that we are seeing, the one originating from the UK, I understand may be the predominant strain by the end of March. But it was only last week when federal officials made investments to track down and start to identify these emerging threats. We are months behind other countries in using tools like sequencing to detect new strains. So if you could speak a bit about how does data play a role in monitoring and controlling the spread of variants? And in the short term, as we prepare for vaccines and booster shots, how can we streamline and increase the genomic sequencing efforts to track down variants?
This is Dr. Turner. I'll start and then let my colleagues jump in. So one of the key components that we've already talked about is contact tracing. So there are sort of clues to whether or not a variant might be detected, and we are watching for those clues, the S gene dropout, for instance. And as soon as we have any inclination that this might end up being a variant infection, we do overdrive on the contact tracing. And so getting travel history, finding out who they were in contact with, who they might have exposed. But we need the data in order to get that done. And we've already had a couple of occasions where it was sort of a scramble to figure out how to get a hold of the person that we suspected to have a variant. Data modernization will assist in us seamlessly exchanging the data with that healthcare provider who calls us on the phone and says, I think I might have a patient who might have a variant, versus, trying to go to other databases to find out what this person's phone number is or what their address is. So that's one of the things that data modernization can do. Also, we are exchanging data with the CDC. So, building that infrastructure so that we can share data very quickly with CDC, not only from the lab perspective, but also from the epi perspective, the epidemiology data, so that it can be brought together to build that picture to help us move policy forward and move those mitigation measures forward. That's all about, that's how the data modernization will help. And I'll defer to my colleagues for some additional elucidation.
Thank you.
Yes. So variant analysis really does come back again to workforce, unfortunately, at least in a public health laboratory. While the testing itself is not highly sophisticated as compared to other things that may occur in our laboratory currently, the analysis of that data is actually quite a unique skill. It's a skill set that in private industry commands over 6 figures for an average bioinformatician. A lot of public health laboratories cannot afford to pay that type of salary to a bioinformatician within the site. In addition to that, from a data modernization standpoint, as Dr. Turner indicated, we definitely have needs for upgraded servers and cloud storage so that we can not only store the data, but we can analyze the data. This data, for lack of a better term, is huge. It's very large, significantly larger than what we would normally store or transmit on a daily basis. Because of that, the servers and the cloud storage is essential to making sure we can do it in the most efficient manner possible. Here in Virginia, we've begun to establish some private and public partnerships. So we're trying to leverage the power of not only the state public health system, but our educational partners as well as our private partners in order to get the amount of sequencing and variant analysis done that's necessary for good surveillance. So that teams like Dr. Turner's team can then move forward with their case investigation and public health measures.
Great. Thank you so much for all your work and your testimony and answers today. Really appreciate it. I yield back, Madam Chair.
Thank you. Thank you very much. We unfortunately don't have time for a second round of questions. So with that, what I'd like to do is to ask Ranking Member Congressman Cole if he has any observations and closing comments, and then I will close it out.
Thank you very much, Madam Chair. Just quickly, I want to thank you again for having this hearing. I think it's a really, really important hearing. I want to thank all of our witnesses and coordinate or congratulate them on coordinating their testimony so well, which I know you didn't plan to do, but you might as well have. And that actually makes our job so much easier when we find such unanimity amongst professionals that we all have a great deal of respect for. So I was particularly struck by that, Madam Chair. And as you know, Madam Chair, we've done this, as chairman and ranking member on both sides for 6 years now. And we've always gotten to the same place at the end of the day. Always been able to vote for the final passage of this bill, regardless of who the chairman happened to be. While I know that there will be differences, it's a big bill and we have obviously differences. This is not one of the areas where we differ. This is one of the areas I think that we can build common agreement on. I was struck by that listening to the questions again and observations from both sides of the aisle. I don't think there's any doubt that we all believe this is an area that we need to make a significant and continuous investment in. And I just pledge to work with you in the weeks and months ahead as we address the difficult issues in the bills and build on the areas that we agree on, because I do believe we agree here broadly and we can find common ground. And honestly, I suspect we will be able to do the same with our counterparts in the United States Senate, which again, we've been able to do 6 times in a row. It isn't just this bill just passed the House. It got through both chambers in one form or another, and that couldn't have happened if we hadn't found agreement with Senator Murray and Senator Blunt and their colleagues. So again, I just end with thanking our witnesses. I thought this was a very, very productive hearing. We appreciate you taking the time. We very much appreciate your professional insights and take very seriously the common ground that you have amongst yourself as to where key investments need to be made. And as one of our colleagues pointed out, I think it was Ms. Roybal Allard, there is a limit that we get to do, but we may be able, given what's happened, to be a little more robust in this area than we've been able to be in the past. And this has been an area where we've tried over several years to make systemic and systematic investments. You've helped us highlight the areas that we ought to be looking at going forward. So I thank you all. And again, Madam Chair, I thank you for this very important hearing and look forward to working with you on this very important topic. Yield back.
Thank you so much. And again, pledge to work closely with you in this particular area because, again, I'm struck as where you are, the power of the presentations and the testimony and the consistency and the revelations of sometimes you can't get witnesses to tell you, what is, they can lay out the problem, but they can't give you any solutions. In this instance, to all of you, are so grateful. You have powerfully expressed the difficulties that you are having in this very critical area. But as important as you provided us with a roadmap of what we can try to do in order to deal with this. And I've got, some of the phrases, and I underlined them in the testimony as well. We don't have a science problem. We have a resource problem. We have to deal with it's predictable and sustained funding, diversity and equity, expanding the public workforce. Everyone has talked about data modernization, and underlying all of that. And it was smart, strategic, and sustained. And I'll put the emphasis on sustained because we have a tendency, as the ranking member knows in Washington, we do this on an emergency basis. We check the box. Okay, yeah, we took care of, public health infrastructure. That is not the case. So that I just want to say to you that we are committed, and you have seen what we have done in the past. We are committed, as you are in your professional lives of doing the jobs that you do, that we cannot go from crisis to complacency to crisis. That is not what we need to do here. And what we have doing is, as I use, and this has become a favorite phrase of mine, is the architecture for the future for our nation's public health system. We will look forward to talking with all of you, getting your views, getting your ideas, even more so than through your testimony, but to help us as we try to move forward and make the investments. This is the investment that we ought to be making, and the results of that investment is saving lives. And so I thank you all again. I thank the ranking member, and with that, let me adjourn the hearing. Thank you.
Thank you.